crazy new thing and compare it to having nothing. Like, no. Compare it to your 13 times greater risk of death being pregnant with COVID.
And compare it to like November when we were walking into the winter with no vaccine. You would have killed for an 85% effective vaccine. So like, I think people need to just take a chill pill and just get the shot. Okay, so I'm gonna go live on Facebook.
Okay.
At the same time, obviously we don't want to dismiss people's fears and anxieties, and fear is justified. It's like, and we also don't want to deny the grim realities that we're facing, but when we can motivate people by hope, I think we are obligated to. Okay, so let's see. I don't know about you, but two doctors talking about COVID-19 vaccines, health outcome. This is and equity issues. That's just so generic.
Sure, because that way, you can talk about equity with pregnant people, with people of color.
Yeah.
Computer, stop making so much noise.
Say something with live. Why did they make you say something? Join us live. Like, thank you, Facebook. Okay. Oh, so I ideally would be able to look at people's questions as they come up. I'll figure that out as we go. I think we're live.
It says that we're live.
Does it?
Yes. On mine just popped up. We're live.
And let's see if it's live on my page. Yeah. Okay. Hello, everyone. It's January. What is it? January 29th.
29.
Oh my gosh. The last day of January in 2021. How are you guys? I am delighted to be here today with my friend that I've known since high school, and fellow physician, fellow champion of women's health, Amanda Williams, who is coming up to us from California. She's an OBGYN. She's an advocate for equity in healthcare and just a generally all around awesome person, and a mother of 2 boys. So we're going to talk about a lot of stuff. Amanda, thank you for joining me today. It's great to see you.
My pleasure. This is, as you know, from my social media, from my work, this is my jam. This is what I'm really passionate about in general, about women's health and equity, but with lots of attention now on COVID and the COVID vaccine.
Yeah, I mean, this is, you have a lot of hats. You wear a lot of hats, like the mom hat, the like Peloton warrior hat. You're Peloton, right?
Yes.
Yes. Oh my God, you're Allie Love.
Yeah.
I love Allie Love. Anyway, and then you're also this doctor, women's health advocate. I mean, you also mentor quite a lot of people, not just your patients, but other members of the healthcare community.
Well, my biggest thing right now, though, is that I'm the assistant chair of the chiefs of OBGYN for Kaiser Permanente Northern California. So I know on the East Coast, there's not a ton of Kaiser, but in Northern California, that's half of all the insured population. So that's 2 million women in Northern California. So I have some reach, and I do the policy and care delivery design for in the pregnancy space. And as you can imagine, we've had to pivot incredibly over this last year, integrating virtual care into our prenatal care and postpartum care delivery. And then now taking care of patients and having systematic approaches to caring for patients with COVID in the hospital, making sure all of our teams have appropriate PPE, responding to changes in recommendations, and now getting our teams and vaccinated, and soon we'll be getting our patients vaccinated also. So it's physician leader work.
It's a lot of hats, and I mean, the amount of reach you have is huge, which is one of the many reasons I wanted to have you on today, because you're thinking from a population health standpoint, how to help women access maternal fetal care, how to access vaccinations, and then on an individual basis, how to counsel people about what they need to help them through pregnancy to be safe, mentally and physically healthy. And then, of course, COVID-19. I mean, pre-pandemic, there was already an enormous disparity in outcomes for a developed country. The United States has terrible maternal mortality rates in people of color. We know that. And then, COVID-19 has not made that any better. So, I mean, maybe we should start with the question of, like, from a population health standpoint, like what are the biggest challenges you're seeing in your population of women as they approach pregnancy in a pandemic?
It's funny. The number one thing I see is their mental health is falling apart. In general, pregnant patients are anxious at baseline, especially the first timers. And then you have the overlay of fear of infection for themselves, fear of infection for their babies, fear of coming into the medical center. What's my actual risk? What's my perceived risk? Then you don't have your structural supports. So if you are in any groups, pregnancy groups, postpartum groups, if your sister was going to come in from New Jersey to come and help you with your baby, or the grandparents were going to fly in from Wisconsin, like that's just not happening. So patients are increasingly vulnerable with decreasing support. And so that has been one of the biggest challenges in my patient population with COVID. And then on the provider side, it's how do we keep ourselves safe when we don't know, who's got what. There is so much. One of the things that makes COVID so different is that there's all this asymptomatic transmission.
Right.
So
that's the main driver of the pandemic.
Right. And so when we don't know, how do we keep ourselves safe? And then how do we keep our patients safe from us? So and then how do we give care well, trying to keep people out of the medical centers, but keeping them safe so that they don't avoid care that they really need. And we're seeing more and more data that whether it's heart attacks, whether it is uterine cancers, we're seeing that patients are not coming in even when they should be because of those fears. So getting that balance right is really tricky.
So and then finally, sorry. Oh, go ahead.
Just the last thing is, how do you give care to pregnant patients with COVID? I mean, I remember in April, we had a case series from China of 10 patients. And then there was one from New York that had 40 patients. I mean, when was the last time you did something medical that was based on like next to
cohort
nothing?
Of 10 people.
A cohort of 10. Right. Like, oh my God.
We call it winging it. We call it winging it. Yes.
So now we know way more, what we're doing and how to do it safely. But this has been one heck of a year.
So tell me some of the things that you do, like you personally, and then you at Kaiser, for example, for outreach. So those women who are naturally, anxious and pregnant and avoidant of healthcare because, whether it's harder to access the clinic because of transportation issues, or they're just afraid of COVID-19. Like, you're just probably like me, you're doing a lot of telehealth.
Mm-hmm.
But someone has to pick up the phone to do telehealth. Like, how do you access people?
So fortunately, inside of Kaiser Permanente, we have really robust systems already in place around telehealth. We have pre-existing appointment types. The majority of our patients have already downloaded their apps on their phones that flow directly into their medical records. So we had that infrastructure to begin with. What we didn't have is clear guidelines about who can do, to be specific, for pregnant patients. Who are good candidates for telehealth? Who are not? Do you need to have a blood pressure cuff at home? Do you need to have a Doppler at home? What conditions exclude you from telehealth, that you really need to come in to check on yourself and on your fetus during pregnancy, which prenatal visits lend themselves better or don't to telehealth visits. And it's kind of funny, but I was supposed to have a girls' weekend the second weekend in March when everything
Probably
blew up.
happen.
And my boss called me and said, "Hey, Amanda, do you think you could throw something together?" And I was like, "So what do you mean?" She's like, "Oh, like design how we can give virtual prenatal care." I was like, "Oh, okay. So when do you think that would be, when do you want an outline?" She was, "Oh, Monday." And so instead of my girls' weekend, I locked myself in a hotel room at the Indian Springs, where I was supposed to be like in the hot tub and getting massages, and designed a preliminary system for how we could get off the ground with virtual prenatal care.
Yeah, it's amazing. That's amazing, Amanda. I like that picture of you getting a massage and a hot tub at the same time, by the way. Yeah, I mean, the technology advances that we have implemented just in my office, would have taken us 5 years, but we did it in 5 minutes. And totally. I had a similar weekend where it was like the hair on fire weekend, where I'm taking every single patient's email address, putting it on a spreadsheet, because we were so primitive pre-pandemic. And that's where my newsletter was born, is to try to get information out quickly to patients, because the phone was ringing too fast for me to answer, and just blitzed it. But yeah, telehealth has provided a wonderful new, and I would say supplementary way to care for patients. I don't think it'll ever replace in-person care. But particularly for people who are, because of physical reasons, or, for people who can't, travel to your office. Like some of my older patients, I'm now seeing them more, because before the pandemic, it was harder to like get a taxi or to drive and park, and so it does offer the opportunity for more access of healthcare to people. But
for a subset of people.
Well, yeah, not everyone has a phone or a computer.
Right. And so that's one of the things that I really take pride in that we are tracking, is to see who are we missing, and what is the impact on disparities, because we want to you could argue it either way, right? It might make disparities better. It might help us shrink disparities, because patients can do their, a prenatal visit from the car, or, their bedroom, because their kids are in online school. So it could make it better, or it could make it worse, because people don't have a high functioning smartphone,
right,
or a safe private place to do their visit, and their intimate partner violence is going unchecked because they're not coming in, and they don't have a safe place to talk to anybody. So we're trying, and that's part of the beauty of working in a big system for me, is that we have all that data. So we're trying to be very intentional about it now that we're taking a step back and doing more design with our stakeholders and testing with patients around some of our virtual tools, as opposed to what we think.
Because just because it makes sense intuitively doesn't mean it translates into real life, right?
Right. Exactly.
Yeah, no, it's easy to say like, oh, now that we have, Zoom, we can reach everyone, but like so many kids who are, not even being accessed by, teachers because of their, lack of universal Wi-Fi. The same goes in healthcare, right? Education can't reach people if they don't have the tools, they need, the basic technology.
Don't even get me started on educational disparities. The health and educational disparities that have happened in this pandemic are atrocious.
They're atrocious, and they track. I mean, there are just so many overlaps there's so many overlaps. And I'm not an education specialist, but I am a mother and I pay attention. It's atrocious. The disparity, the gap is widening every single minute of every single day. And what's fascinating to me in public health, in the public health world, is this maybe seemingly obvious point to you, but like it's very easy to underestimate things we can't easily quantify. Like, for example, you can never be faulted, or it's hard to fault a school for like shutting from a purely preventing death standpoint, preventing infection standpoint, from closing a school, right?
Mm-hmm.
But the social emotional losses and the devastation to kids' beings from not being in school is enormous, and it's hard to measure those. First of all, you can't access all the people who are deprived of educational resources to even know how bad they are, right? And it's just a lot. So it's easier to measure like death rates, case rates, percent positivity of tests than it is to measure softer things like depression, anxiety, suicidality, and a lost generation of kids who are at home and sometimes not safe. I mean, the same thing is in healthcare. We can measure cholesterol, blood pressure, COVID plus or minus, but it's a lot harder to measure people's anxiety, fear, vulnerability, their relationship with their provider. Like, how does their relationship with you, Amanda Williams, as a Black doctor, affect their outcomes if they are a person of color themselves? Like, how do you measure that, and how do you weave that into the algorithm to then give the best care? In other words, it's a long way of saying it's about measuring the hard science, but it's also about measuring the human condition, and those things are sometimes hard to quantify.
Absolutely, which is why things like patient interviews, patient focus groups, we have a really robust health education division, and I mean, there's going to be, millions of PhDs are going to happen because of what's the last year.
Yeah, they're being hatched by like little like chicks and eggs. Millions.
Anyway, but to be able to figure out what is it that patients need, where did we go wrong? And we have a big tracking system around peripartum depression. And so I'm fascinated. I can't wait to see our data, see what has happened to our patients. And we've got plenty of anecdote that they are having a really hard time. And we've had to stand up all these programs to try to make counseling happen virtually, to try to make groups happen virtually. But just the day-to-day in and out living, I think even just about myself and my kids, we're very privileged and still having a hard time. And my 16-year-old was being a total jerk the other day. And I thought, no, wait a minute. He's not articulating Mom, it's hard for me because I'm not seeing my friends at school and I don't have those touch points. But that is real. That's part of, what's going on with him.
Absolutely. Yes, I agree. There's so much that there's so many disparities, as we've already touched on, and we'll talk about more. But there's so much we have in common right now, that we're all experiencing loss, vulnerability. Our lives have been upended, but of course, for people who have resources, it's a different ballpark altogether, right? It's different. Yet at the same time, we're all human, and we all are entitled to feeling, sad, lonely, and isolated when that is what's going on.
I use that as a launching point a lot now that I'm talking about the vaccine.
Let's talk about it. Yeah.
Because part of my talking points are all about we're in this together. I'm experiencing this and you're experiencing this, and try to sort of shrink that space between what the doctor wants you to do and what the doctor's going to do for herself. And I think that that's part of the power of the relationship with the clinician, because it really can help build trust. All of us want to go and see our parents. All of us want to go and have a dinner party. We all want this. And so part of getting there as a society and as a community is going to be getting vaccinated. But it is not an easy sell, because there's lots of well-founded distrust.
There's a lot of well-founded distrust, and I'd love you to talk about that. I would totally agree with you that in public health, as you know, the messenger is as important as the message. And right now, as I was saying to you before we went live, my pet peeve is like the understatement of the year. I have a bee in my bonnet, whatever you want to call it, about the messaging around the vaccine. The vaccines that we have right now, the mRNA vaccines, the Pfizer, Moderna shots, are some of the most amazing technology we've ever produced in the world. They're 95% effective at preventing COVID-19 and 100% effective at severe disease. Basically, when you've had both shots, 2 weeks later after the second shot, you are immune. Does it mean you can rip your mask off and start, licking other people in the grocery store? No. Does it mean that you're not going to be hospitalized for COVID-19? Right. It means that. Is it possible? Yes. Is it possible to be hit by lightning and, fall into a manhole on a random Tuesday? Sure. But it's very unlikely. And so what's bothering me is the negative spin on what the vaccines can't do for us, when actually they can do so much. They can really start to give us our lives back. The J&J vaccine information is starting to come out. It is 85% effective in a global phase 3 trial. That is phenomenal. If you had said to us back in July that we had an 85% effective vaccine, we would be so happy. Yeah. And the more vaccine we get out there, the better. Of course, you and I would probably both like to have the Pfizer or Moderna more than the J&J, but you could also get the J&J now and then wait till there's more Moderna and get it later. I think the point is, you and I, as clinicians, as messengers, need to do the best we can, and hopefully this is part of it, to help people understand the facts, understand the benefits to their day-to-day lives of vaccination, and also dispel myths. But talk about, I know where the mistrust of the medical community comes from in, Black America. I mean, there's Tuskegee, there's Henrietta Lacks. I mean, there's tons of precedent for abuse of Black bodies by the medical profession. And I'm interested to hear, how much does that come up, overtly when you're talking to patients, or is it sort of a meta message that you're hearing?
Both. There are patients who are aware of specific studies that know about the Alabama hysterectomies, where people go in for an appendix and you come out with a hysterectomy, about Tuskegee. And, some people have this mindset oh, this is a long time ago. This is history.
1972.
Yes, we were born in the 70s, my friend. This is in our lifetime.
1974 is when Tuskegee ended.
Yeah, and I was born. So,
yeah,
and so
I was
were
too.
you. So, it is. This is real. It's modern life. Even in the camps down in the southern border of Mexico, there are some involuntary sterilizations that are going on now, specifically for Mexican immigrants. So this is not ancient history. This
Right.
is something that is present. And even for patients who don't articulate exactly, what are the studies and what's the why, there is this sense of being out to get us, or not listening to us. And, there are studies on believing that Black bodies don't have as much pain, and not listening as being part of the big health disparities that we see with Native American women and Black women in the United States, who have 3 to 4 times the rate of death around childbirth. There are reasons that this distrust occurs. So when I talk to my colleagues about how do you build trust with patients, and honestly, even in our own medical centers, there are a subset of staff who are really afraid of getting the vaccine and have this mistrust.
Half of my staff, I'll take a little stroll through my lab every now and then, and just say, okay, let's talk about the vaccine. But there's mistrust. And I get it. And so, like you, my job is not to shame people and say, hey, come on, wake up and smell the coffee, but rather say, yeah, where's that coming from? Let's understand where that's coming from. Or if you don't want to tell me, let's talk about like what questions do you have about it?
Yeah. And to build that trust, I think having the humility to acknowledge the history is incredibly powerful. And that's sometimes hard for white people to do. And to not be afraid of saying the word racism, not being afraid of describing the mistreatment, and say, and not making it about that person necessarily. It's like, hey, some of my patients who are Mexican are aware of these involuntary sterilizations. Is that a part of what's coming up for you? Or some of my Black patients who are aware of the Tuskegee study or Henrietta Lacks or, whatever it is, feel a deep distrust because this is a new vaccine and they know about experimentation on Black bodies. Is this something that's coming up for you?
That's great. That's great language. And I think, for people who are watching, who are, going to work, even on Zoom, and like have the opportunity to talk to coworkers, neighbors, friends who are hesitant, that's really good language to use when you're trying to kind of understand why someone might be hesitant.
And then to think about like the FAQs, right? Is there actual COVID in it? Am I going to get COVID? What about these side effects? To talk to people about them. I mean, the risk of anaphylaxis, and especially death from anaphylaxis, is so incredibly small. And so what I always try to do is compare it to something people do regularly.
Yes.
So I say this actually all the time with blood transfusions, which is if you drive on the freeway, which pretty much everyone does, your risk of death is 100 times higher than if you get this blood transfusion. And you don't every day sit in your car and say like, oh my God, I'm not going to go into this death trap on the freeway. You do it because it's a small enough risk. And this is orders of magnitude safer.
Yeah, I think we're dealing right now with such unbridled anxiety that is founded in reality, right? We are dealing with a horrible situation in this country. But I think when we're anxious, and I do this myself, right? You stick to the sort of negative news. So I was talking to a patient of mine last week. I was asking her about getting the vaccine, and she said, oh no, I'm not going to get the vaccine. I heard about that Florida doctor who just died after getting his vaccine. So he died a couple weeks after his second dose of the vaccine. We have no idea whether or not the cause of his death was the vaccine. He might have been on the road to dying for some other reason. Yet we know that 400,000 Americans have died from COVID-19, 2.1 million people around the world have died. We know, so, but it's interesting. And I said, I wonder if you realize that's natural to feel anxious about death, right? Like that's a real worry, but that's an anecdote when we have all this evidence from trials, tens of thousands of people. So, it is interesting. I think you have to, as you said, meet people where they are, understand their anxieties, understand their, where they're coming from. And then try to dispel the myths and reassure and, hope that most people take the vaccine, because ultimately the more people who take it, whether or not the vaccines are 100% effective, is more steps towards us getting our, some sort of normalcy back.
And really getting to the point that we have herd immunity between the people who've had COVID and people who've gotten vaccine.
So can you tell me about who? So what are you telling people about the vaccine in pregnancy and in breastfeeding?
So, and this speaks to a larger research problem, is that so often new drugs, new vaccines exclude pregnant women and breastfeeding people. And that is a pre-existing problem. And, I can imagine as a drug manufacturer, you're like, oh, that's a hot box. I don't want to go there. I'm just trying to get my drug to market.
Yep.
But by excluding people, that means we don't have as good data to make recommendations. So our recommendations have to be based on history, on the history of what we know about similar vaccines, what we know about the risks of the illness, what we know about this technology, because this is a very different type of vaccine, and then anything that's coming out of the registries, and then what a patient's real risk is. So I always say you cannot compare to nothing. It's like, what is the risk of the vaccine compared to no vaccine? But that's not the right comparison group. You have to say, what's the risk of vaccine compared to the risk of COVID? And so taking that into, so that's why it really has to be an individual decision. And there's nothing about the vaccine that would a priori say that pregnant people or breastfeeding people should not get it. So I think, honestly, and I didn't ask your permission to say this, but the World Health Organization is totally irresponsible for the statement that they put out earlier this week, not recommending COVID vaccine for pregnant patients. And American College of OBGYN, Society for Maternal Fetal Medicine, CDC, came out hard in the last 2 days, say against the World Health Organization, saying that
I think I totally agree with you. And there's more and more data, I think, that came out, is it this week, from the University of Washington about maternal mortality and poor outcomes when pregnant women get COVID-19.
Okay.
So
you are 13 times more likely to be hospitalized if you are pregnant and get COVID compared to your non-pregnant same age peers.
Yep.
So this is, it's not a joke. Like, pregnancy and COVID is really bad.
Yep.
And I have taken care of these women. This is not something that you want. So if you have a living situation, a work situation that puts you at higher risk for getting COVID, it should be a no-brainer. If you work in healthcare, if you have a family member that you live with who is an essential worker, if you are in multi-generational living situation, if you're a teacher, if you're going to have exposures, I strongly recommend pregnant people getting vaccine. For breastfeeding people, even more so, because you actually might be preventing your baby from getting
I think people
COVID.
forget the reason, like, I nursed my kids for a year each and pumped and just, that was a labor of love. And the reason is, one of the reasons is you're conferring your immunity, your immune system, and the antibodies you have in breast milk to your baby. And so it makes intuitive sense that you would then want the vaccine to then protect your baby.
Totally. And that's what and that's why it's surprising that there's so much concern around breastfeeding, because if anything, it's the opposite, that there might be additional benefit. The other thing is to keep remembering, this is not like rubella, this is not like varicella, these are not live vaccines. In fact, there's no COVID in it. It is the programming to make part of the protein that your own body is making it. It's almost like you get a shadow, you get the reflection, your body makes that protein, and then you make the antibodies.
Someone made the analogy, it's like sending your body an email to the instructions on like how to make the spike protein, and then the email gets deleted. And I thought that was good. Although the electronic analogy, I worry that it triggers people to think about like
radiation.
But yeah, there's no way to get COVID from the vaccine, just like there's no way to get the flu from the flu shot. Just little FAQs that I'm getting right now and that people are writing in right now. Like, if you had COVID-19, do the antibodies you now have circulating in your body protect you against the new variants? The answer is yes. The current vaccines that are out there, the Moderna, the Pfizer, and the upcoming J&J vaccines, yes, protect against the new variants, which makes intuitive sense, by the way, because the virus hasn't seen enough, it hasn't bounced off enough people who are vaccinated to outsmart the vaccine yet. Will it at some point? Will the virus outsmart the current vaccines? Probably, but that's something I'd worry about later. and right now just get your vaccine because they work. Do they work as well against the South African variant? Some of them don't, but working less well it doesn't mean they don't work at all. And as I was saying today and on Instagram, let's not make the perfect be the enemy of the good. Right now, these vaccines are really, really, really astonishingly great. Let's just get them into people's arms. And I'm hoping that the new administration follows through on their promises to deliver more vaccines, to coordinate better with states, and to get them out into people's arms.
It's been so tough, and I know there's huge state to state variation.
Yeah.
But a colleague of mine gave a great analogy. Is inside of Kaiser Permanente, we have millions of members. We have really strong infrastructure. We're trying to get a direct contract to vaccinate the whole population because we can do it. We can roll this out, but we can't even handle. We don't have enough vaccine. We have the systems to do it, but we just can't get enough vaccine to take care of our population the way that we want to. Yeah. And so my boss said, it's like going to dinner, you see the menu, you tell them what you want, and then they bring you something entirely different.
Yeah, they're like they tell you the specials, and they're like, oh no, we just ran out, and you see the person next to you eating it. You're like, you're like Dover sole, and you're like, what? Yeah, and my patients, probably like yours, the ones who do want it and can't get it, are really, 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 really distressed, and I would say in some cases unhinged. And I understand it. It's almost worse to have the shot in the city that you live in and not be able to access it than to not have it at all. It's torture. It's a waiting game. But I am hopeful that the Biden administration again is promised more doses. If Johnson & Johnson is approved next week, we will get those out there. I know they're being shipped as we speak, right? Because they want to anticipate the emergency use authorization by the FDA. So hopefully that will happen. And I would say this to people who, let's say J&J gets approved and you can get the J&J before the Moderna, which is, technically a little bit better. Take whatever shot you can get. Let's not be picky. And I don't think we're going to have a choice either.
Yeah. No, I mean, we just need to get it in people's arms. When my own parents had a really hard time battling, and they're in DC, battling the DC government scheduling system to get their vaccines, and they were like up in arms. Yeah. But now that we are all vaccinated, I'm getting on the airplane. I'm going to be in DC in 2 weeks.
Oh my gosh, that's amazing.
So, because I'm a month or 6 weeks out from my vaccine. My parents will be 2 weeks out, and I haven't seen them in almost a year. So
there's an example of like the real world application of having been vaccinated. You have been vaccinated. You are immune. There's a very you're 95% protected against COVID-19. Did you get Pfizer or Moderna?
Pfizer.
You got Pfizer, so did I. And then your parents are also completely protected. Now, the vaccine studies didn't use the endpoint of transmissibility as the thing they were studying. So we don't yet know if the vaccine prevents transmission of disease. But can we just say this out loud? I would really like to continue to say this. Just because we haven't shown that yet doesn't mean it's not true.
Right.
It stands to reason that a vaccine that is as good as Moderna and Pfizer will also prevent some form of transmission, and probably a lot of transmission. I mean, it just makes intuitive sense. Again, we can't say that for sure because we don't have scientific proof.
But it's going that way. The data is looking like that's the direction. And there's a New England Journal article from this week. That it looks like that's going to be the case. We can't say it with confidence yet.
We can't say it with confidence, but it's like the same thing. You can't say that when you use a condom and birth control pills together that you're not going to get pregnant, but like you probably aren't, right?
Right.
I mean, it's not the same thing, and there's the sex analogy is always fraught. But the point is that like the chances of you Amanda, or me, Lucy, having been vaccinated, carrying asymptomatic COVID in your nose, and then giving it to your parents who've been vaccinated and sickening them, I mean, that's just impossible practically. Right. I mean, It just wouldn't happen. I mean, the airplane travel is interesting. I mean, you're going to, I'm sure, wear a mask.
Of course.
Be super careful because you don't know if you're going to carry it and transmit it to someone else. But again, that is so unlikely. And your mental health, I'm going to assume, is going to be better, and your parents too, for seeing them.
Yeah. And that's what I want for my patients. That's what I want for everyone.
I know.
Is to be able to spend time with their loved ones.
That's the end point.
That's what we oh my God, I'm feeling like verklempt.
Yeah, oh my God, cry. If you can't cry on Facebook, when can you cry? Yeah, no, that's the end point. That's what we want. That's the holy grail.
My mom's really end of life, and I don't know when the last time is going to be that I get to see her. And the fact that I get to see her one more time, and I live across the country, is very important to me.
Yeah, you're not going to make me like misty-eyed. It's very, very important. And those are the things you cannot measure in a study, right? You cannot measure. Right. So when a public health expert says that that an unvaccinated grandchild needs to quarantine for 2 weeks before seeing a vaccinated grandparent, I say this: I hear what you're saying, but let's think about real human beings here and the odds of infecting a grandparent when they've been vaccinated. It's so small, and the benefits of a hug of a grandchild. So there's no, just like you, I don't tell people how to make decisions. I don't tell them what to do. I give them the facts and help them make smart decisions. But the chances of infecting a grandparent who's been vaccinated, particularly if you've been vaccinated yourself, is very low. And then if you have been not vaccinated, it's still extremely low. And it may be a risk that you are worth taking. I mean, it's interesting. I think one of the reasons, I'm interested in your thoughts, Amanda, one of the reasons why public health experts aren't celebrating the things we'll be able to do when we've been vaccinated is I think because they're worried that people are going to start, flouting taking masks off. They won't understand the nuances, like they would go on planes and not wear a mask. Mm-hmm. And then there's equity issues there. Like, not everyone can travel, not everyone can get the vaccine. So like, I understand why we don't want to be flashing our vaccinated status, but at the same time, we all want the same things, right?
Right. Even though my partner and I were talking about getting T-shirts that say like "I'm vaccinated," or having like vaccination parties, so that people.
I mean, if you go on Twitter and did that, you probably get some haters. Like,
totally.
They'd be like, yeah, you are a privileged
Totally.
Bragger.
You're a bunch of privileged physicians, and you want to have a dinner party with your other privileged physicians, which is true, and we also have a responsibility to stay conservative. We have a responsibility to keep using our PPE and to keep distancing, because that is saving lives also. And it's going to take the better part of this year to get very wide vaccination in the country.
Yeah.
So we have to stay mindful, and there are too many people who are actually not doing it, and we don't want to co-sign on that behavior.
Well, that's it. You don't want to celebrate the upsides and then create a contagion of throwing the baby out with the bathwater. We don't want people to stop masking. But I think if you understand the facts and you understand your status and you have calculated your risk reward ratio, and you're using, your intentions are good and you're being safe, and you understand that your actions affect others always, not just in a pandemic, then that's good.
I just think people in general, and it's not the most conceptually easy thing, don't think about the risks that they take every single day, right?
Yeah.
Every time you have sex, every time you drive a car, every time you fly in an airplane, like all those things are risks that you take with your life. Yeah. And there are not a lot of people who are sitting there doing those relative risk assessments.
Right.
And it's probably more healthy that they don't, because you drive yourself
you become
bananas.
Like an OCD, right? And you would never leave your house.
Yeah. Right. Yeah. But there's nothing that's zero risk.
That's correct.
work super hard and mitigate our risk as best possible, the better off we will be and the happier we'll be also. And our well-being matters.
It matters. It matters. And I think, to your point, we don't think about all the risks we undertake every day because we become inured to risk, like getting on the Beltway in DC. It's probably not safe because, as I think it is. Similarly, I think we really underestimate our impact on other people. I think we tend, we're a pretty individualistic society, right? We see people in Walmart like screaming into someone's face for making them wear a mask. Like, liberty and freedom means I don't have to wear a mask, but that's an extreme example. But in general, I think we're pretty individualistic as Americans, and the pandemic has forced us to think about how our behaviors affect other people. When we go to a restaurant, for example, even if we feel fine, we may be carrying COVID asymptomatically and give it to someone else in the restaurant. And so that's been, and that's, when you talk about equity and, others, I hope that we've learned some lessons from the pandemic in that regard, because as much as we are in this together, it's created divides, but we still are.
People aren't behaving that way.
Right.
Yeah. And it actually makes, I have to check myself because it makes me angry.
Oh yeah.
When I see people being sort of irresponsible, not caring, not wearing their masks, not spacing, and because we are responsible for each other. And it might not be about you, but if you live with your grandmother, like that's a really big deal. So you might want to go to a party and not wear your mask and think because you're 25 that the risk isn't a big deal and COVID's not a big deal. My two friends had it and all they had was a cold. When you're coming with that mindset, it's really problematic. But for people who have this exaggerated sense of individual rights being superior to public health and public well-being, setting up this false dichotomy, which I feel like has been done. I'm not going to start finger pointing on the who has done it, but this doesn't, public health and individual rights do not have to be in direct conflict with each other.
Yeah, they're not mutually exclusive.
Right.
Yeah, I've had to battle, like as you suggested, some feelings of anger, just seeing people. Anyway, we could go on, sort of ignoring public health measures, people who are sort of just don't know what they don't know, and I think are blind to their own privilege, which I think we're acutely aware, some of us hopefully are more acutely aware of our privilege. And what's so, I'm not, and I don't feel like I need to apologize for who I am, but I hope that I'm still trying to know what I don't know, right? Like being aware of privilege and aware of things that I don't know. So what's fingernails on a chalkboard to me is seeing people blind to their own privilege and then flaunting it. It's just like, hey, it makes me crazy. I'm sure it makes you crazy too.
Oh yeah.
Anyway, we could go on, but
yeah.
but what are your sort of like, main takeaways from the pandemic with regards to like pregnant women? Like what are the sort of like main like lessons or summary points key points that you'd want to make to like make sure that everybody here who's listening to us knows? And by the way, we have a lot of NCS viewers here, which is awesome. Our alma mater. Like what are some like main if you had to like say like three things that you wanted people to go home with about maternal health and pregnant women in COVID?
One would be the risk of worse outcomes from COVID itself are real. So yes. Do your best to keep up your masking, your distancing, and get the vaccine when and if you can, especially if you are a healthcare worker or any other kind of essential worker or teacher, somebody with a lot of contacts. So that would be one. Two would be, if you have access to virtual care, take advantage of it. See what your doc or midwife can do with you online. Find prenatal classes, chat groups with other prospective birthing people. Pregnancy can be isolating, especially postpartum can be isolating. So whatever you can do to keep up with community is a good thing. And then lastly, I would say, let your community work for you. So even if you can't, your neighbors can't come over to see the new baby, they can drop by dinner on the doorstep.
Yeah. Like, say yes, basically.
Yeah, exactly.
Accept help.
Right. So in any form, whether it's, a meal, whether it's diapers, or even like a load of laundry, like take your giant thing of laundry, put it on the stoop and have somebody bring it back to you at the end of the day. Just let people help you, because it's a time when folks are more isolated at baseline, and particularly now with COVID.
I think those are great points. And I think they also apply to non-pregnant people.
Yeah, true.
It's like, in fact, I'd love someone to do my laundry right now. And but in all seriousness, I mean, one of the terrible ironies of depression, for example, and I have so many patients who are isolated and depressed, and some of them are single, but some of them are just isolated, even though they have a family and a spouse, and and feeling lonely and depressed and down and hopeless. The irony of depression is that you tend to focus inward and not ask for help and sort of pull the covers up and not reach out. So whether you're pregnant or not, I think it's always important to ask for help. As I tell my kids, it's a sign of strength. Ask for help. You aren't expected to know how to do everything, and particularly when you're in a pickle, people want to help you. So I think that's a good sort of general life lesson. And then just for mental health in general, connecting with other people. We know how important that is for our health, our overall health. It helps tamp down adrenaline and cortisol, our stress hormones, being with other people and getting some exercise every now and then, being in nature. It's freezing cold in DC right now. I don't know what it's like in California. I don't really want to know. It's so cold.
It's like a beautiful sunny day, but it's cool.
Okay, fine. So, well, it's like, it's like that awful wind that cuts into your face, and it's supposed to snow. So the snow will be nice, because at least you get some benefit of the cold. The snow is coming tomorrow. But yeah, Amanda, you're so fun to talk to. I could talk to you for hours, and I'm really hoping you have a wonderful visit with your parents. Yay! It makes me happy to think that's going to happen for everybody.
In 2 weeks from today, I will be in DC, and I feel like it's a COVID vaccine victory story.
Valentine's victory.
Totally. That I've been able to take care of patients with COVID, design care for patients in this pandemic, and now I have my vaccine, and I can do little things that matter to me, like fly across the country and see my
well deserved. And your parents, I can't even imagine what it's going to be like for them to like hold you and like hug you. It's going to be so nice. You have to take some selfies.
I know. Don't worry. The Instagram and Twitter feeds will be healthy in a couple of weeks.
Amanda, it was so nice talking to you. Thanks to everybody for listening and watching. And if I missed questions here, I'll try to get to them later. Happy Friday, everyone.
Thank you so much for having me.
Bye, Amanda. Talk to you soon.
Take care.
Take care.